Welcome to the weekly Neurology Deep Dive. I am your host, and today we are heading straight into the outpatient clinic. You know the scenario well. You have a patient with long-standing diabetes. Their hemoglobin A1C is perhaps controlled, perhaps not, but their primary complaint isn't the blood sugar numbers, it's the feet. They describe burning, tingling, or that sensation of walking on pins and needles.
It's one of the most common consults we encounter. And usually by the time they reach a neurologist, they've already tried gabapentin, perhaps they're on pregabalin or duloxetine, and they're looking for something else.
And they often ask about options that are, well, not standard anticonvulsants or antidepressants.
Exactly.
And that brings us to the supplement aisle. Today, we're tackling a molecule that sits right on that line between metabolic support and symptomatic management: alpha-lipoic acid.
It's a polarizing topic. I mean, some clinicians swear by it. Others believe it's merely a placebo. It's time to look at the actual data.
Before we analyze the evidence, I do want to give a shout out to our producer, Amer Gavanini. Amer puts these deep dives together, and we appreciate the work. Now, for the standard disclaimer, this weekly neurology deep dive is for educational purposes only. It has no commercial goal. It's a summary of the literature, and we always recommend that you read the full paper yourself. We are not giving specific medical advice here.
Understood. So let's look at the paper.
We are reviewing a systematic review and meta-analysis. It's titled Effectiveness of Alpha-Lipoic Acid Supplementation on Biochemical, Clinical, and Inflammatory Parameters in Patients with Diabetic Polyneuropathy.
And this is by Alain Vergara Salinas and colleagues, published in Diabetes and Metabolic Syndrome. Clinical Research and Reviews in 2026.
So a very recent publication. The clinical question we're trying to answer today is pretty straightforward. Based on this specific data, should we, as neurologists, recommend alpha-lipoic acid supplementation to patients with diabetic neuropathy, or are we simply helping our patients create expensive urine?
If you're in a rush and can't stay for the full analysis, here is the practical summary up front. The data suggests that alpha-lipoic acid, specifically at a dose of 600 milligrams per day, is effective for symptom management. It significantly reduces pain, paresthesia, and numbness. It also appears to improve lipid profiles.
Okay, but there's a big however coming, isn't there?
There is. However, and this is a major caveat, it does not appear to improve nerve conduction velocities or glycemic control. It is a symptomatic treatment, not a disease-modifying cure for the nerve damage itself.
That is the bottom line. 600 milligrams is the target dose, and we are treating symptoms, not the underlying axonal loss. So let's unpack how they reached that conclusion. What was the methodology here?
This was a systematic review and meta-analysis of randomized controlled trials. They cast a wide net initially, but ultimately included 15 articles in the qualitative review.
And for the actual numbers, the meta-analysis.
For that, 11 of those studies were suitable for the quantitative meta-analysis.
And what kind of patient population are we looking at?
It's a respectable sample size. They included a total of 2,218 patients across all these studies. The trials compared alpha-lipoic acid, administered either orally or intravenously, against placebo or other therapies, such as vitamin B12 or epalrestat.
And the dosing varied, I assume.
It did. The doses ranged from 300 milligrams all the way up to 1,800 milligrams per day. But the analysis really, it heavily focused on that 600 milligrams per day dosage, which seems to be the standard therapeutic window.
Geographically, where were these studies done? This is important for understanding if the results apply to a diverse patient base.
It's a pretty diverse group. We have data originating from Korea, Greece, China, Germany, India, Mexico, Italy, Russia, and Israel.
That's significant, because diabetic phenotypes can vary based on diet, genetics, and lifestyle. Seeing efficacy across that many different healthcare systems and, well, genetic backgrounds, it strengthens the argument for generalizability.
I agree. It helps.
So let's get into the clinical efficacy, specifically the symptom scores. This is usually what the patient cares about most. Did they feel better?
The short answer is yes. They used the total symptom score to evaluate this. 7 studies evaluated the total symptom score against placebo, specifically at the 600 milligram dose.
And the result?
A statistically significant reduction in symptom scores to the alpha-lipoic acid group compared to placebo.
What was the effect size there? I mean, statistical significance is one thing, but clinical relevance is another.
A fair point.
Yeah.
The mean difference was negative 0.7 points. Now, that might sound small on paper, but in the context of chronic neuropathic pain, a reduction of nearly a full point on a composite scale is clinically meaningful for the patient.
It's the difference between pain being a constant distraction versus, say, background noise.
Exactly.
Let's break that down by specific symptoms. Diabetic neuropathy isn't monolithic. You have positive symptoms like burning and stabbing, and negative symptoms like numbness. Did it help with all of them?
It was quite broad in its efficacy. 4 studies showed a statistically significant reduction in the burning sensation.
And paresthesia?
4 studies also showed a significant reduction in paresthesia, that uncomfortable crawling or tingling sensation. And perhaps most importantly for functional sensation, 4 studies showed a significant reduction in numbness.
That is notable. Numbness is notoriously difficult to treat. We can often mask pain with sodium channel blockers, but bringing back sensation or reducing that wood-like feeling is rare.
It is rare. And the data regarding stabbing pain, that lightning bolt sensation patients often describe, was also positive. 2 studies showed a significant reduction in stabbing pain. So across the board, whether it's burning, tingling, numbness, or stabbing, the 600 milligram dose moved the needle in the right direction.
You mentioned dosing earlier. Did the higher doses, like 1,200 milligrams, work better? If 600 is good, is 1,200 double the benefit?
Not necessarily. The 1,200 milligram dose also showed significant reductions in burning and paresthesia. However, the 600 milligram dose is the primary focus of the recommendation because it offers the best balance between efficacy and safety. There's no linear relationship showing that doubling the dose doubles the relief, but it certainly increases the risk of side effects.
Were there other pain scales used besides the total symptom score? Sometimes that score can be a bit subjective.
Yes, they looked at the Hamburg Pain Adjective List. 2 studies showed a significant improvement, meaning a reduction in pain, with a standardized mean difference of negative 1.6.
And the neuropathy impairment score.
They looked at that too. 3 studies showed significant improvement in the global score, and also specifically in the neuropathy impairment score for the lower limbs.
So we have multiple scales all pointing in the same direction. Subjectively, and on clinical examination scales, the patients appear to improve. Now, this is where it gets interesting. We often assume that if the symptoms improve, the nerve must be healing. What did the physiological outcomes show?
This is the divergence point. Despite the symptom relief, the electrophysiological data does not show significant repair. They looked at the peroneal motor nerve conduction velocity. In 2 studies comparing 600 milligrams of placebo, there was no significant difference.
And sensory nerves, since this is largely a sensory neuropathy?
Same story. For the Schurl sensory nerve action potential, across 6 studies, there was no significant difference.
That is a stark contrast. Patients report feeling better, but the nerve conduction studies are flat. Why do you think that is?
Well, the paper hypothesizes that while the symptoms, which are often driven by hyperexcitability and inflammation, do improve, the actual structural damage, the axonal loss in the Schurl nerve, may be irreversible.
Or it just takes longer to heal.
Or it simply requires a much longer duration than these studies allow to show any electrophysiological change. We might be soothing the nerve without rebuilding the highway, so to speak.
That's a critical distinction for neurologists managing patient expectations. You might feel better, but your EMG might not look better. We're treating the physiology of the membrane, not the anatomy of the nerve trunk.
Precisely. We're optimizing the environment for the nerves that remain.
What about glycemic control? Alpha-lipoic acid is often touted in diabetic circles as a way to help manage blood sugar. Does the data support that?
The data says no. 4 studies showed no significant difference in hemoglobin A1C levels between the treatment and placebo groups.
And fasting glucose.
3 studies showed no significant difference in fasting plasma glucose either.
So we should not be viewing alpha-lipoic acid as a glucose-lowering agent.
Correct. It's not a substitute for metformin or insulin. It acts via different mechanisms.
However, there was some interesting metabolic data regarding lipids, right?
Yes, this was a positive finding. 3 studies showed a significant reduction in total cholesterol, and 2 studies showed a significant reduction in triglycerides.
Do we know the mechanism for that?
It's likely linked to the antioxidant effect. Alpha-lipoic acid helps prevent low-density lipoprotein oxidation. It also aids fatty acid entry into the mitochondria. Essentially, it helps the cellular machinery burn fat more efficiently, which reflects in the lipid profile.
Speaking of antioxidants, did they measure oxidative stress markers directly?
They did. They looked at malondialdehyde, which is a common marker for oxidative stress. 2 studies showed a significant reduction, which confirms the proposed antioxidant mechanism of action. Interestingly, they also looked at nitric oxide levels and found no significant difference there.
Okay, let's talk about safety. We're recommending 600 milligrams. Is it well tolerated?
Generally, yes, but it's not without side effects. The predominant adverse effect reported across several trials was gastrointestinal issues. Nausea was the primary complaint.
Any others?
Other reported effects included vomiting, diarrhea, and abdominal pain.
Is this dose dependent?
Very much so. The adverse events appeared to track with the dosage. There was specific mention of vertigo being observed at the higher 1800 milligram dose. This reinforces why the paper suggests that 600 milligrams is the safe therapeutic window. You get the symptom relief with lower risk of making your patient nauseous or dizzy.
That mention of vertigo is a major red flag. I mean, think about the population we're treating. We have patients with numb feet. They often rely heavily on visual and vestibular input to stay upright because their proprioception is compromised.
Precisely. If you take a patient who can't feel the ground properly, and then you give them a high-dose supplement that induces vertigo, you are engineering a fall risk. You're creating a hip fracture waiting to happen.
That reinforces the 600 milligram argument significantly. You get the symptom relief, but you stay below the threshold for vestibular toxicity.
Exactly. The risk-benefit ratio heavily favors 600 milligrams. There's no strong evidence that 1200 or 1800 milligrams provides twice the pain relief, but the risk of nausea and vertigo definitely increases.
Let's synthesize this. How exactly is this working if it's not fixing the nerve conduction? You mentioned oxidative stress, but connect the dots to the pain.
It's about the microenvironment of the nerve. Oxidative stress is a key driver of diabetic polyneuropathy. It damages the vasa nervum, the blood vessels supplying the nerve, and it irritates the nerve fibers themselves.
And that irritation leads to the burning sensation.
Yes, the oxidative stress leads to hyperexcitability of sensory fibers. It also seems to modulate abnormal sodium channel expression. We know that abnormal sodium channel activity correlates with those burning and stabbing pain sensations. So by reducing oxidative stress with alpha-lipoic acid, you are essentially stabilizing the membrane. You are dampening the hyperexcitability, which treats the pain, even if the conduction velocity of the nerve trunk hasn't returned to normal.
It's essentially quieting the noise in the damaged nerve. Now we have to look at the quality of this evidence. Is this a high certainty recommendation?
We have to be realistic here. The certainty of evidence, using the grade assessment, was generally rated as low or very low for most outcomes. And why is that?
A major factor is heterogeneity. In the meta-analysis, the heterogeneity values were often above 60%, and in some cases, even above 90%.
For the listeners who haven't looked at a forest plot recently, what does that high heterogeneity imply for clinical practice?
It means the study results were variable. Even if the average was positive, the individual study results were inconsistent. This could be due to different populations, different durations of diabetes, or variations in trial design. It means the signal is positive, but it's noisy.
So neurologists should monitor individual patient response closely. It's not a guarantee that every patient will respond the same way.
Exactly. It's a viable option, but clinical monitoring is absolutely required.
Okay, so let's put it all together for the clinician listening while driving to the hospital. We have a patient with diabetic neuropathy, complaining of burning feet. Their hemoglobin A1C is controlled, but the pain persists. Based on this review, alpha-lipoic acid is a very reasonable add-on.
And this prescription would look like?
Alpha-lipoic acid, 600 milligrams daily, oral administration.
And what do we tell the patient to expect?
We tell them that this helps control the symptoms, the pain, the numbness, the tingling. We can tell them it might help their cholesterol a bit too, but we should be clear that it will not lower their blood sugar, and we need to watch out for nausea. If they get an upset stomach, that is a common side effect, and they should let us know.
And we should probably explain that this is a long-term management strategy, not an overnight fix.
Absolutely. Antioxidant therapy generally requires consistency. It's not like taking a non-steroidal anti-inflammatory drug for a headache.
It's interesting to see how the lipid profile improved. That's a nice bonus in a diabetic population that is already at high cardiovascular risk.
It is. Reducing total cholesterol and triglycerides is beneficial in this demographic. It speaks to the systemic metabolic benefits of alpha-lipoic acid, even if it's not potent enough to shift the hemoglobin A1C.
I want to circle back to the nerve conduction findings. It's fascinating that we can have such a disconnect between the subjective experience and the objective measurement.
It raises a fundamental question about what we're treating. Are we treating the electrophysiology, or are we treating the patient? If the peroneal motor nerve conduction velocity doesn't change, but the patient can sleep through the night because their feet are not burning, that is a success.
It is, but it also hints at the limitations of our current therapies. We are managing the fallout of the damage, but we're not necessarily regenerating the nerve.
That's the ultimate goal, disease modification. Alpha-lipoic acid is helping the environment of the nerve reducing the oxidative stress, but it might be asking too much of a single supplement to reverse structural axonal death that has happened over years of hyperglycemia.
So, to wrap up the evidence, we have a systematic review and meta-analysis. 15 studies. Positive for symptoms, positive for lipids, neutral for nerve conduction and blood sugar.
That sums it up.
And the mechanism is reducing oxidative stress and stabilizing sodium channels.
Correct.
It seems like a tool that should be in every neurologist's toolkit for this condition. It's not a magic bullet, but it's a solid adjunct.
I agree. It is a viable add-on therapy. It addresses the quality of life, which is often the patient's primary complaint.
Before we close, I want to leave the listeners with a final thought on that disconnect we discussed.
Go ahead.
If the patient feels significantly better, significantly less pain, less numbness, but the nerve conduction studies remain unchanged, are we treating the nerve or are we just treating the perception of the nerve? And in clinical practice, does that distinction actually matter if the quality of life improves? We spend so much time chasing biomarkers and improved velocities, but at the end of the day, the patient just wants to walk without pain. Maybe symptomatic relief shouldn't be viewed so negatively.
It's the difference between treating the scan and treating the human.
Exactly. That is all for this weekly Neurology Deep Dive. We will see you next time.